So we are online.
Good evening, everybody. So, welcome back again for this new episode of Pure Urology. Sorry for this delay because we had a little bit of a small technical glitch. So, today we are discussing on reimplantation of a transplant kidney. And we have eminent speaker, Dr. Abhay Mahajan, sir, who has been doing these transplants since many days. And we are grateful to have you over to join with our Pure program, sir. Welcome, Abhay, sir.
Thank you.
So today, Dr. Abhay Mahajan is a consultant professor in urology and kidney transplant surgeon. He's working at Sai Urology Hospital, and he has been the professor and head at MGM Medical College and a kidney transplant surgeon at Care and Medicover Hospitals. He has many 30 publications, authored one book chapter, and he has been conducting many regular endourology training program at Sai Urology Kidney Hospital on PCNL, mini PCNL, RRS, and TUFLEP. He has been the operating faculty for PCNL, RRS, and in our own workshop of TUFLEP versus HOLEP. He was our faculty here. And he has held many positions like a secretary of Aurangabad Urological Association 13 to 16, council member of West Zone from 2018 to 2020, organizing secretary of West Zone USA conference on 2016 at Aurangabad, and he's been currently the president of Aurangabad Urology Association. So without much delay, I would request Abhay sir to go ahead with his presentations.
Yeah. Thank you very much, Siddha. I'll share my screen and we are already late, so I think we should start the presentation immediately. So today I'm going to speak on anterior ureteroneocystostomy. How do I do it? So this is a simple surgery, but if anything goes wrong in this surgery, the complications which we have to face, like re-exploration or doing a redo ureteric anastomosis or doing a complicated anastomosis like native ureter to the transplanted ureters, these are all difficult surgeries which you have to perform. So the first surgery is the best surgery, which should be done with complete meticulousness, and that can give the best results for us after kidney transplant surgery. So anterior ureteroneocystostomy in kidney transplant patient, the four most important points when we get the kidney from the donor surgeon or from after donor nephrectomy is to have a good periureteral tissue, to preserve the golden triangle. This is the golden triangle, which is the triangle which extends from the hilum to the lower pole of the kidney and the ureter which is cut. So the vascularity at this point should be maintained. So the foremost important point in this is to protect the lower polar vessel, because if there is a lower polar vessel, however small it is going to supply the upper ureter. So you have to protect the lower polar vessel and re-anastomose the lower polar vessel in the recipient surgery, because that is going to give a good outcome or good anastomosis of the lower polar vessel will give good vascularity to the upper ureter and prevent further complications. Now, there are some cardinal principles or some principles which are to be followed. Ureter is to be dissected along with the periureteric tissue. The ureter should not be skeletonized or denuded, because once the ureter is denuded, then there will be loss of vascularity, which will give rise to some impaired ischemia to the lower ureter, and the anastomosis can give way or become necrosed, and there will be a urine leak. So avoid skeletonization. That is the first and the foremost point. You have to tell the donor surgeon or the person who is doing donor nephrectomy, whether it is open donor or laparoscopic donor nephrectomy. The second point is to create a tension-free uretrovesical anastomosis. Now, there should be no stretch or traction. The ureter should lie freely till the bladder. Even if there are some slight C-shaped laxicity in the ureter, or if the ureter is excess, there is no problem, because the urine is going to drain nicely from the kidney to the bladder through the lumen of the ureter. But if there is stretch or traction, then the anastomosis will again be under tension and can lead to devascularization. The ureteric part towards the bladder also should be straight. The excess angulation should be avoided. If there is excess angulation, there will be blockage, or there will be kink in the ureter, which can lead to obstruction, and obstruction can again lead to impaired ureteric anastomosis. So these are the three cardinal principles which you have to follow when you do an anterior ureteroneocystostomy in kidney transplant patient. So we'll just go to a very short video, and this is a simple video but showing the complete steps of the surgery. So
Right.
before we start the anastomosis, you have to fill the bladder. Now the most important point in this is you should not overfill the bladder. If you overfill the bladder, then the mucosa will pout out, and your scissors or your mosquito or your instruments can just puncture the bladder mucosa, and there will be multiple rents or holes in the bladder mucosa. So optimum distension of the bladder is the most important step. We usually distend the bladder not more than 200 to 300 cc's. So that is enough to distend the bladder. So it is not excess, it is not less. If it is less, then the bladder mucosa or the bladder will keep on going in the pelvis. It will not come out of the pelvis, and doing dissection of the bladder will be difficult if it is underfilled. So overfilled bladder will give stretch on the mucosa. Underfilled bladder will not allow you dissection. So should be optimally filled with around 300 ml of saline. Now, there are few people who put betadine or some antiseptic solution, but frankly, those are not required. A good saline, sterile saline with an asepto syringe, which is newly opened for each transplant. We open new asepto syringe for each and every transplant. So it is not ETO, or it is not put it in Sidex. So the chances of infection are less that you are introducing into the bladder when you are filling it through the Foley's catheter. So 300 cc's of sterile saline with sterile asepto syringe, and complete system should be sterile when you fill up the bladder. So once the bladder is filled up, then you can mark the incision with cautery like this. The length of the incision, as you all know, should be around 1:5. So that is around, the ureter is 5 millimeter. So a 2 centimeter long serosal incision is usually enough. 2 to 3 centimeter is usually enough. If the ureter, you feel that it is slightly dilated or a bigger caliber ureter, you can have a longer tunnel. Anyway, the tunnel is preparation of the length of the tunnel is usually very easy in transplant in the normal bladder, which is recycled. But if the patient is anuric, then sometimes the bladder is small, and creating a tunnel becomes slightly difficult. So this step shows the incision of the detrusor muscle. The mucosa is kept intact. The detrusor is now nicely cut. Around 3 to 4 centimeter, 2 to 3 centimeter of tunnel is enough. Once you cut the detrusor, then you create a plane between the mucosa and the detrusor. Now this step is important because you want to close the detrusor over the ureter. And if this dissection is nicely done, then there is no compression of the detrusor on the ureter. If you don't adequately dissect this and try to approximate the detrusor muscle on the ureter, then the ureter might get compressed or get pressed against the inadequately dissected detrusor. So nicely, these flaps should be created. These are known as detrusor flaps, which are created between the bladder mucosa and the detrusor muscle.
Right.
Here you can see gentle dissection is done, and undermine this at the distal end. Now, why to undermine this at the distal end is at the end of the anastomosis, we are going to bring out the suture material through this so that the ureter goes below the detrusor. So the chances of leak through the anastomosis are less. Once this is done, you open the bladder at the end of the dissected point so that the ureter will lie on the mucosa. The ureter is now spatulated at 6 o'clock position so that it rests nicely on the bladder, and the anastomosis is started. We usually first do the medial part of the anastomosis, that is the medial end of the bladder with the medial end of the ureter. This is usually done with 6O PDS. 6O PDS is what we use under magnifying loop. And if you can see, once that medial edge is completely done, now Siddha, there is no knot. But once we take first suture, if you see
Hmm.
the
Hmm.
PDS is kept taut with by the assistant. There is
Yes, yes,
knot
double R.
at
It's
the V portion, so that there is no stenosis or constriction. Okay.
nice. Yeah.
And we will do the medial edge, then we will do the lateral edge, and at the end there will be only one single knot, which will be at the end of
Yes, yes.
12 o'clock
Hmm.
position of the ureter. So this is end of the medial portion, and usually we don't keep any DJ stent in all our transplant patients. So that is our
Okay.
routine protocol, not to put a DJ stent. So the chances of
Mm-hmm.
infection, stent related symptoms, one more
Mm-hmm.
procedure of removing the DJ stent is avoided. This point is controversial. There are few people who regularly keep stents, but this discussion will go on and on.
So one more doubt, if we are using a single stitch like this, is there a
Yeah.
risk of crumpling of that suture like
No, yeah.
uh,
So what you do is you keep the other end taut. If you keep the other end loose and you try to pull, then it will get constricted. Once that is taut,
okay,
and once you go ahead with the sutures, it will remain like that in the same position. So now
okay,
I'm starting
okay.
the other end, that is the suturing the lateral edge of the ureter to the
Mm-hmm.
lateral edge of the bladder mucosa.
Mm-hmm.
And once this is undermining the ureter. See, one
Right.
needle will come out and then the other will come out and be tied that. Once that is done, then you do the detrusero-raphy. That is suture the detrusor over the ureter. This is usually done with 30 vicryl with interrupted sutures. So that if you have continuous suture, there will be constriction effect, and interrupted suture. Another advantage is, suppose there is some minor oozing or some minor urine leak, it will come out and it will not compress or obstruct the ureter. So that is the
Yes.
point in taking interrupted suture, and it will allow the ureter to expand between the detrusor sutures, so that the ureter will not get compressed because of continuous sutures. So
Right.
always 2 to 3 interrupted 3O vicryl are enough. And this is the detrusorography which is done at the end of the procedure. We do put stent, but that is in some indicated patients like
Okay.
neurogenic bladders or patients having renal stones, or the bladder mucosa is very thin and it is there is whole multiple rents in the mucosa in cadaver transplant. So these are the indications. Now this last step which you have seen, we put the needle holder
Instrument inside.
through the
Yeah.
detrusor muscle and the ureter, and this is the ureter which is nicely lying. That is the cord which is on the ureter. So this is a short video which shows the ureteroneocystostomy.
Right.
In post-operative care, the Foley's is usually removed after 7 days. The drain is removed once the output is reduced or stopped. And stent, if we place, we remove in 4 to 6 weeks.
Yeah.
These are the usual complications of 1 to 3% of urinary extravasation and leak, which usually requires re-exploration and repair. Ureteric obstruction in 3% of patients. If it is short segment, then you can do endoscopic intervention. If it is a long segment, you can do a repeat surgery. So my argument of not putting a stent is, in our experience of more than 600 transplants, we have an ureteric injury or a leak or redo anastomosis in about 2% of the patients. So what I feel is that unnecessarily in 98% of the patients, you're putting a DJ stent, which usually can be
Not
avoided
required.
in this. So in 2%
Agreed.
of
Agreed.
patients, you can always take that risk. We are keeping our data and following up all our urinary complications till date, and our complication rate is around 1.5 to 2% till date. So without putting stents for most of the patients, I would not say all, but only few
Okay.
patients, about 10 patients must have required DJ stent by now. So transient voiding insufficiency, but that is rare in a kidney transplant patient. So again, if is ureteric stent required, so the advantages are avoids ureteric complication. If there is a leak, it is easier to manage. But the disadvantages are 90% of the patients have unnecessary stents. The chances of urinary infection, if the stent migrates, there can be stent migration or incrustation. Then, of course, there is no evidence of patient of graft survival if you don't put a stent, and the patient usually has some discomfort because of the bladder spasms. That is a short
Nice, sir. Nice,
presentation,
sir.
Siddha. Yeah, if we can
Yeah.
have discussion. Yeah. So I'll just
Super,
stop
sir.
sharing the screen.
Yes, please. Yes, please. Right.
Once.
So that was an excellent short and a beautiful video, sir, explaining all the basic steps
Thank
of
you,
how
sir.
to do a urotomy cystostomy.
Yeah.
Couple of questions. So when do you prepare the bladder? Is it at the starting of the procedure or you do at the end?
Yeah, usually what we do is as soon as we dissect the vessels, we always keep the bladder prepared and ready before the kidney comes. Because once you do the vascular anastomosis and then put the kidney there and then start doing the bladder dissection, sometimes it is difficult because the space is less once the kidney is already
Yes,
there. Secondly, the
agreed.
urine will keep on pouring in the field. So you will have to suck the urine
Agreed,
in
agreed.
between and, it will be disturbing for you. So it is always better that you keep the bladder ready. We inflate the bladder, we dissect the detrusor, we open the mucosa as I've shown you. We drain the complete bladder, then we put a gauze piece and just put a stay sutures on the detrusor which are kept away from the field of the vascular region. So bladder
Right,
is
sir.
always prepared first. Yeah.
And what is your preferred line of incision? Either it is horizontal, vertical, or oblique. How do you decide what makes you to take that call?
On
Some
the bladder.
people, yeah, and some people do a horizontal, vertical. Some people do towards the bladder neck, oblique incision.
Yeah.
So,
Yeah. So usually slightly oblique incision is better because the ureter is coming from a lateral part. The kidney is going to
yeah,
go in the
yeah.
iliac fossa. So the ureter is coming from lateral part to the medial part of the bladder. So if you take slightly oblique incision from bladder neck towards lateral part of the bladder, the ureter very nicely sits on the bladder till the end of the mucosal incision which you have made at the bladder. So a
True,
straight
true, true.
incision might keep a small curve to the ureter, but a
Yeah,
slight oblique incision
it's
is
like
always better.
following the natural curve of the ureter over to the
Yes,
bladder.
so
That
yes,
gives
so
better
that is always
results.
the better.
Yes.
And if you keep the ureter that way, once the kidney is placed, you will see that the incision will go from the lateral part of the bladder towards medially towards the bladder neck. So
Yes,
that
sir. Yes,
incision
sir.
is better. Yeah.
What do you do, sir, whenever you have a thick bladder? How do you proceed? And if
Yeah.
there is any injury to the mucosa while dissecting the tunnel, how do you
Yes.
proceed, sir?
Yeah. So if there is an injury to the mucosa, it is always better that the mucosa is sutured with a PDS before you start the anastomosis. If the bladder is
Okay.
thick, then the detrusor or raphe doesn't come well. The detrusor is either, once you start suturing the detrusor on the ureter, it will compress the ureter. So in those cases, what we do is, one thing is you try to dissect the detrusor as more as possible from the mucosa so that it sits
Okay.
properly. In spite of that, it is not sitting, then you can take only one or two sutures on the ureter. The detrusor sutures, instead of four, you can cut down to two. Uh,
Yeah.
doesn't mind, sometimes there is a chance of reflux because of small short length detrusor because of the thick detrusor, but you have to accept that. But if you try to take more sutures, it will obstruct the ureter. That is one thing. Secondly, if such things happen and the mucosa is getting torn off before the procedure and the detrusor is very thick, then you have to put a stent, because stent is going to save your chances of ureteric leak and from the ureteric anastomosis site.
Right, sir. Done. So what will be the tips if we have a short length of ureter? How to
Short.
proceed there? Short length come ho gaya. It is not
Oh,
reaching or it is very
okay.
taut.
So the donor
Yeah,
surgeon has given a short
short
ureter.
ureter.
Yeah.
Very rare, but still it's
Yeah, yeah,
possible.
I agree. Sometimes it can happen, Siddha, because we have been doing transplant since almost 20
Yes,
years
sir.
and
Yes,
all
sir.
sorts of such complications we have seen. And it is not the fault of donor surgeon, because sometimes he feels that the ureter is
That is
adequate
enough.
and
Yes,
he feels
that
that
much.
this should be enough, and it becomes a very short ureter. So that also we have seen. So one thing is, if it just sits, you take the incision more laterally as possible so that the ureter reaches. And in spite of that, if the ureter is not reaching the bladder, then you can take the native ureter and anastomose the native ureter to the transplanted kidney ureter. So that is the best solution for this short ureter. But don't try to pull the ureter and take it to the bladder, because that traction and that tension will not be suitable for the anastomosis site. It can give way, or there will be a complete urinary leak after the anastomosis.
Yes, sir. Yes, sir. So any chance of psoriasis or mobilizing the bladder on the opposite side and bringing the bladder towards the ureter will be
Yeah,
helpful?
that also can be done, but there is a chance of temporary bladder hypotonia in
Yes,
such
yes, yes,
cases.
I agree.
And
Yeah.
then bladder has to be mobilized a lot if you want to really take it to the psoas. Then
Mhm.
another point is the kidney is already sitting on the psoas. So
Mhm.
taking a suture from the bladder to the psoas below the kidney again sometimes becomes difficult. So instead of having this extensive dissection, you can just take the native ureter and anastomose to that is the simplest surgery because native ureter is right in
It
front
will
of
be,
you. Yeah, right?
ureterostomy,
Yeah.
that will be more than
And
better.
just take it to
So,
the ureter
yeah,
and
yeah, yeah.
anastomosis. Yeah.
So many of these cases, the stent removal is a big headache, sir. Probably you're not putting so many stents, so you would have not encountered. It
I
will be
know.
hell to visualize the stent and to take
Yes,
it out.
yes,
Yeah,
yes,
it
yes.
will be lying
Sometimes,
above into the dome. Short
yes.
length stents, they are
Correct.
really headache.
And especially in male patients, you have to really dip
Yes.
the
Yeah, yeah.
cystoscope sheath so down to see the stent which is at the roof, and
Yes, sir.
you are not able to catch the stent sometimes properly. So I do agree removal of stent should be done by a senior, at least some senior urologist, not a junior urologist in your team, and
Yes, sir.
they should
Yes.
know where they should find the stent at the roof of the bladder.
So
Yeah.
anytime you had a difficulty in putting a stent, sir, you have, as usual, you're doing without stent. Did you
Yeah.
had any chance to put back the stent post-operatively?
Yeah,
Any
post-operatively,
chance?
we had our share of urinary complications. So this was only technical, this thing, so I have not included that.
Yes, sir.
So, if there is a short segment stricture or there is a minor urine leak, we have put a stent. Putting a stent
Mhm.
is also a very difficult
Very difficult.
task for a
True.
transplanted patient. So
Mhm.
you should have a flexible ureteroscope. That is
Mhm.
must if
Mhm.
you are putting a
Mhm.
stent. With the flexible ureteroscope, at least you can see the orifice. You can put a terimo, then you can
Mhm.
remove, once you put a terimo, you can remove the flexible ureteroscope and then push the
Mhm.
stent with a
Stent
routine
inside.
cystoscope sheath. So that is usually the procedure which you can do. And
Right, sir.
if stent is not possible, then you have to go for a PCN,
Mhm. Mhm.
percutaneous
Mhm.
nephrostomy, and then do a nephrostogram and then repair the leak site or the
Right,
anastomosis
sir.
tube
Right.
site.
Done. Naresh, any questions in the
Yes, sir.
uh,
Dr.
questions in
Ramakrishna.
mind?
Yeah, Unnai,
Yeah,
sir. Dr.
yeah.
Ramakrishna. Sometimes ureter look little long and we hesitate to exercise.
Yeah.
So,
Yeah, there is no problem. If the ureter is long, you can just take the ureter at the cystostomy site and you can
mhm.
just keep slightly about 1 centimeter of excess of ureter. Or you
Okay.
can just see how the ureter lies from the kidney to the bladder. Some
Mhm.
excess ureter should be kept and the remaining ureter you can easily excise. There is no problem.
Mhm.
So
Mhm.
if the vascularity is good and there is good periureteral tissue, excision of ureter usually don't give rise to any problem.
Right, sir. Right, sir. Done. Mhm.
So one more, sir. Sometimes we feel ureter is looking long, but hesitates to exercise. Is there any specific measure to prevent long lengths?
No, see, it all depends on the donor surgeon. Sometimes the donor surgeon dissects very nicely beyond the crossing of the iliac vessel and cuts the ureter there. So if that length of the ureter is given by the donor surgeon, usually that is a very long ureter. So that much of ureter is not required. We don't want to keep a long ureter which will cause multiple kings or
Yeah.
multiple excess ureter which is lying and which can get obstructed. So it should be, the length should be appropriate. It should not be straight to the bladder, which can give traction or tension, and it should not be very lax. So, little bit of small, lazy C appearance of the ureter from the kidney to the bladder is enough. And the rest of the ureter you can easily cut or excise and do the anastomosis. There is no problem.
ఇంకేమైనా ఉన్నాయా నరేష్?
No more questions, sir.
Okay. Thank you, Abhay, sir.
Okay.
In spite of the initial glitch, it
Yeah.
went well.
Yeah.
Hopefully, it will be helpful for all the juniors who are starting the transplant. It will
Yes.
be a memory to watch this and then go ahead with the surgery.
Yes.
Thank you, sir. We'll get back to you with some more videos again in future. Right?
Thank you. Thank you, Siddharth.
Thank you, sir. Thanks a lot,
Thank
sir.
Thank you. Thank you. Thank you.